And now we shift to HIV. And we are very honored to have Francois with us. He is a clinician working here in South Africa. And you remember all the nice things that Justice Edwin Bernard said about him. And so, just like any other amazing person in the field of HIV, they are humble. They do not like their whole CV being read out. But I want to reassure you that you have one of the best brains in this particular area. So feel free to shoot the hard questions around transmission, risk, exposure, and whether it's possible to deliberately infect another person. Maybe he could give you scientific figures as to how that happens. So we're going to listen to him, and just like we had the session before lunch, Edwin will come in, who's not a stranger to us, to sort of lead that conversation so that then we can ask some of the questions and have a discussion. Dr. Francois, we have with you a number of lawyers and journalists from more than 10 African countries who are interested in listening and deciding what would be their role in trying to address laws or policies that criminalize HIV infection or TB exposure, and how would they be able to use the science, because as a lawyer you have to understand the facts. And so what are the things they really need to know to be able to make an informed decision around cases they're litigating or cases they're taking forward. So the floor is yours. Welcome. Please, a round of applause.
Thanks, everybody, and thanks for the kind words. And this is going to be a way of turning you into HIV experts, if it's at all possible. And I think it actually is possible. There's some very simple concepts around HIV that you need to internalize, and then you will be experts. In fact, you probably will know more about HIV than most doctors, certainly that I deal with. It's been an interesting thing working with human rights groups and patient activist groups and others over the last 20 years that I've been a doctor working in HIV. But I still am so struck at the levels of stigma and morality and stupidity, actually, to be quite frank, that I'm faced with. I was at a dinner party about 9 months ago, sitting white, middle-class South Africans, sitting around the table, about 6 or 8 of us, and there was a couple there who I actually treat for HIV, but who've kept it completely silent. They've internalized it, they've dealt with it, but they're HIV positive, and this dinner table got onto sexual morality and why people have HIV, and people had maybe a little bit more to drink, but the offensive things that got told, assuming everyone was negative in that audience, was really like brought home to me like how much nonsense actually still, and how much fighting we still have to do around things around conventional morality, conventional thinking. Just before I came here, there's a very famous politician who was posting on Facebook about blessers and about older men having sex with younger women. That's how the HIV epidemic is driven, and that's nonsense. But it suits a certain moral discourse within the society, and therefore people are happy to get behind it. And I'll show you some of the data from that, and why we have to be quite careful not to let our intuitions, and our moral intuitions in particular, cloud what is actually what the science is telling us when it comes to HIV. And I think with the transmission criminalization debates, that's very, very important. And I'll throw up some of this stuff. And then at the end of it, I just want to challenge a few of you in terms of some of the groups where there are debates around HIV. So the first fact is the HIV, what we call the pathogenesis, how HIV causes harm, is actually really easy to understand. I'm going to show you a model that is many people think is patronizing, but this is how I teach my patients. It's how I teach my doctors, my medical students. And this model has been, it's not my model, it came out just over 20 years ago. It's about, it's called the train on the track model. And you just need to know 2 concepts. You've all heard of the CD4 count, which is a mark of, of immunity, and you've also all heard of the viral load, which is how much virus is in the bloodstream. If you have those 2 concepts in your head, you pretty much understand HIV. So what you've got to think about is a train heading down a track, okay? That train is, that length of track is your CD4 count. A normal CD4 count's anything between 800 and 2,000 cells. That steadily goes down as HIV gets worse and worse and worse. And without antiretroviral therapy, that speed of the train varies, but it goes down in almost everybody. There are a couple of things that people talk about in my world that are supposed to slow down this train, most of which actually don't work. The things that actually accelerate the train are actually few and far between. Things like exercise, safe sex do nothing to the train, paradoxically. Things like smoking do accelerate the train. Drinking too much actually does nothing to the train. Snorting cocaine, oddly enough, does nothing to the train. But in my world, often the morality I was talking about clouds this. Is like you must live the perfect life if you're HIV positive. I mean, I often look at that and I actually want to drink and a cigarette just looking at that as a HIV negative person. You know, it's like the stress we put on our poor patients who must now suddenly overnight transform, often with no resources, into these perfect human beings when nobody does this, you know, to be quite frank. But this is unfortunately how the morality of medicine has permeated the society. But finally, what happens is you need antiretroviral therapy. The speed at which you move down this track is called the viral load, and that's the amount of virus. The minute you take your antiretrovirals, the viral load goes down to 0, and in fact, your immune system starts recovering and your train goes backwards. You stop your antiretrovirals, the train starts going forwards. You don't take your drugs correctly, you get resistance, the train starts going forwards. So, just to summarize, the train is the patient, the length of track is the CD4 count, the speed at which you're going down is the viral load. You take your ARVs, your train goes backwards. If you stop taking your ARVs, your train goes forwards. If you don't take your drugs correctly, you get resistance, the train goes forward. That's all you need to know about HIV. Honestly, it's that simple. And that is the model that's been operative for over 20 years now. So what we have at the moment, we've spent a huge amount of time in the past talking about where on that train, when do we start the antiretrovirals? Now, we've always had to weigh up, on the one hand, the cost of the drugs and the toxicity of the drugs. The prior generations of the drugs were actually very, very toxic. So you didn't want to take drugs because, you know, they would make you sick. So you wanted to delay for as long as possible. So you wanted to weigh up getting sick, the risk of getting sick versus the toxicity of the drugs. So we spent years, decades, talking about the when to start debate. And you'll hear this often is, amongst my generation of doctors, that this is what we kept ourselves occupied with. However, we've got to the stage where the drugs now are so safe that debate's been swept away. You can start the drugs at any point because the drugs are, one, so safe, and two, we actually recognize there actually is harm, even when your CD4 count is actually quite high. And we'll come back to the other benefits of antiretrovirals in just a moment. So now we just start everyone as quickly as we can. When they're ready, we start them preferably on the same day. And there's a fair amount of data to suggest that actually starting the day of diagnosis is actually a pretty good idea, particularly in the poorer communities that we see. There are all sorts of caveats about that. If people are in denial or they're not in the right space to take those drugs, that it is quite a complex decision. But it's that safe and that effective that we're actually considering that. And for the South African government, it's national policy at the moment to start on the same day unless there's a compelling reason not to. So we've gone from a situation where we're subdividing and subdividing and subdividing which risk group to start. We were talking about intravenous drug users, we were talking about gay men, we were talking about sex workers, pregnant women, all these groups, and this circle got bigger and bigger and bigger, and now the circle includes everybody, which actually simplifies programs dramatically, which is find the person, assess them for antiretrovirals, get them onto antiretrovirals as quickly as you can. And this term, test and treat all, find and search and treat has now crept into the language, and now the CD4 count is no longer a measure that we use to start antiretrovirals. We used to use illness as well, but the commonest reason to start antiretrovirals or to limit antiretroviral therapy was the CD4 count. So that's gone, and a good thing too it is, because it has made the program that much simpler. I cannot emphasize, most of you are not medical. Medicine moves very, very, very slowly. You'd be shocked at how slowly. Most diseases, the kind of changes we see in the treatment of things like diabetes, hypertension, stroke, cancer, are tiny incremental. The headlines often are like, there's this new miracle treatment for this form of cancer or that rheumatoid arthritis. When you actually go down to it, it's often just a slight improvement on previous therapies. Antiretroviral therapy is right up there with penicillin and insulin. It has completely transformed a disease that killed everybody pretty much, and now turned into a disease where it's actually controlled with 1 tablet once a day. The impact on life expectancy, so here, this is coming through from the 1950s.
Sorry, the translators.
Oh, sorry, I'll try and go a little bit slower, or just say less. So this shows you so remember HIV came about in Africa sort of mid-80s, late 80s, early 90s. You can see how life expectancy went up and up and up in all our countries. And that was because of clean water, vaccine programs, better housing, better ventilation, sanitation, all the good stuff. And what happened as HIV took hold, you can see this dramatic decrease in life expectancy, which is largely driven by TB and HIV. But you can see how it's got better suddenly when we got the ARVs. This is how profound antiretroviral therapy has been in terms of changing people's lives. But it's much easier to show you pictures. And in fact, my experience is those graphs do nothing for politicians. Treating their sister or their domestic worker is what changes their minds. And this is a very famous Haitian patient who Paul Farmer uses the photographs of. But you can see you take people who are walking skeletons and you transform them back into everyday human beings. And this is how you change people's minds. I used to have, South Africa has very peculiar politics, but the way and unfortunately lots of people shared those politics, all you do is you treat that person's sister, their domestic worker, their gardener, their uncle, and they change like this. And you do this, and what I want to say is this is not an aberration. This is not a special patient. This is how most of our patients end up. You take them, you fix them, they're better. The other thing that's been incredible has been the impact on children, both preventing HIV and also treating them. And this is a patient from one of the pediatric clinics. This patient was obviously on antiretrovirals. Ashraf Kuvadia, who looks after this patient, says the only side effects in children are they get fat and they get naughty. And I think that it is incredible, though, that we're dealing with people who were infected with HIV at birth, who got the HIV as they were from their mom, who are now having their own children. And it's an incredible testament to the efficacy of the drugs to see that. So what we have at the moment is this incredible situation where people who are contracting HIV are actually living normal lifespans, and in some cases, in certain countries, longer than the average population. And that's probably because they're getting medical health care. So I never go and get my flu vaccine, I don't get my cholesterol checked. If I was in an HIV program, I get yelled at about my smoking, they'll tell me to lose weight, to exercise, all the good stuff that I don't normally do. And I think this is an incredible testament, again, to the drugs. It is complicated by the fact that people who start the ARVs late tend to have consequences going into the future, and we're still trying to work what that means. But for the average healthy person who starts HIV treatment, they're going to be facing grandchildren and great-grandchildren, just like HIV-negative people. And this means things like HIV and aging becomes a much bigger deal. First-line antiretrovirals are not perfect, and a lot of the work I do is related to try and find safer drugs. I don't want to give you the impression that there's nothing wrong with current antiretroviral therapy as used in Africa at the moment. So the one drug we have a real problem with is a drug called efavirenz. It's still a very, very good drug, but it does carry some side effects for a small proportion of patients. And a lot of our work is trying to fix that. This is first-line therapy for 90% of people in the world at the moment, including a large proportion of people in Europe and America. And trying to make treatment safer is important. I think what I sometimes get frustrated with my field is we're so focused on the side effects that the stuff which actually is important in terms of keeping people on treatment, poverty, keeping their jobs, trying to deal with alcohol abuse, trying to deal with mental health issues is actually probably far more important than the side effect profiles that we're treating at the moment. And one of these drugs that I'll come back to if we do have time and if people are interested is a drug called efavirenz, and it has warts. It's a big step forward from where we were 15 years ago when this drug first came on the scene. But it's a drug that we now are looking at going to replace over the next 2 to 3 years with a much more powerful, safe drug that we're hoping will transform first-line therapy and at least make for that small proportion of people who can't take treatment that much safer. This shows you how we're dealing. These are the various breakthroughs. I'm not going to bore you by going through them. But at the moment, the biggest breakthrough in the last 10 years has been the introduction of a drug called tenofovir to replace the drug called stavudine. But we've now got efavirenz about to be replaced. And now we're looking at things like injections. There is a drug being evaluated at the moment, which will be an injectable once a year. So you will get rid of the tablets altogether with a little bit of luck going into the future. So the drug discovery part of it is actually very, very exciting. I mean, I'm loath to say it in an audience like this, but often when I'm teaching my medical students, I say to them, I'd much rather have HIV than tuberculosis or diabetes or anything else because of this. You know, there's excitement, there's continual research taking forward safer and safer compounds. So whether you're HIV positive or HIV negative, this is the kind of concept we're starting to look at. Is we're dealing with a situation where, you know, in richer countries and in countries which are becoming richer, we're getting rid of infectious diseases. Not totally, but we're making real inroads into trying to control things like tuberculosis and pneumonia. Now we're dealing with things like stroke, heart attacks, the other stuff that kills people, and cancers. And trying to get to the stage where we're all living to be 80 or 90 years old is the challenge at the moment for people like me and the people dealing with antiretrovirals. And we often talk about this as having a really good life until you drop dead on the golf course at the age of 93. Okay, and the thing is that is a lot of what we're talking about, is how can people lead a vital, healthy life without over-medicalizing them on the one hand, but also not ignoring the fact that there are other diseases other than HIV which are steadily becoming more important. The problem we have is that HIV remains pretty bad. And in that little circle there is about 70% of everybody with HIV in the globe sits in that little circle. So people do tell me it's a big problem in Argentina and in Australia. It is orders of magnitude greater in sub-Saharan Africa. And when I say sub-Saharan, I mean very southern Africa. It's scattered, and it's not to say that it isn't a clinical problem elsewhere. It's just the intensity of the problem in our area, especially in places with very poor healthcare systems, makes it an incredibly compelling reason to focus on it. I think you've heard of the 1990s. Find 90% of the people who've got HIV, get them onto treatment to make sure 90% of them have got viral suppression. We're not doing a great job at that. Even in countries, there are a few countries which keep claiming that they've done a good job. Botswana, Malawi, Rwanda, to a lesser extent, South Africa. But overall, some of those numbers are disputed, but also overall, we haven't done a wonderful job. And certainly if you go into rural South Africa, that's what we call the cascade, going from diagnosis down to being on successful therapy, is actually not great. But again, it's important to come back to the human face of what this is. And the human face is found in antenatal clinics and contraception clinics. It's found in schools. It's found in poor communities and in rich communities. But in places where, screening people walking through the door, we've been running these programs in clinics across South Africa at the moment. We're still finding 10% of people walking through the door have undiagnosed HIV. It's that serious still, is that you can simply walk down the streets and touch every 10th person, and that person has undiagnosed HIV. It's a shocking way to think about a country that seems to have trouble even coming to terms with the fact that HIV is still a problem. Tom has spoken about tuberculosis. I probably just reinforcing what he said, but to my mind, tuberculosis is one of the most catastrophic failures of researchers, public health people, policy people, activists, lawyers, everybody. They have a collective responsibility for a preventable, treatable disease that is an absolute disaster at the moment and continuing to be a disaster. And I think that when it comes to TB, the people in this audience, I worry about HIV, but I know how to protect myself, and I know the treatment's great. I don't know how to protect myself really from TB, and I know the treatment is terrible. So again, when we're thinking about this from a policy perspective, this is the orphan of the HIV world. And the only reason it's changing is because some HIV activists are actually getting involved in tuberculosis, but it needs a lot of help. And if any of you are in a position to do that, please do that. Infectious diseases doctors are quite happy about this. They'll tell you that they'd rather have HIV any day of the week than tuberculosis. And I, honestly, when I see some of the consequences of TB patients, this patient, by the way, is a patient, a friend of mine, Brahmi Veriavan, I looked after a couple of years, over a decade ago. This patient's cured of their TB. Okay, what we call a TB success. They're sitting at home, they can't get out of their wheelchair because they're so dependent on the oxygen. This is the success of the TB program. And you have to ask yourself, the success for an HIV program is that guy I showed you, that Haitian patient earlier. The sad reality, and this is where the transmission debate and where you guys come in, is that HIV prevention remains a bit of a disaster. I guarantee that every one of you here has an opinion on what we should be doing, what we shouldn't be doing, and what we should be taking forward. And I just want to challenge you a little bit because I'm not really clear. Some people say, we could have sorted this out in the early 90s. If you had made me health minister in 1993, I'm not quite sure what I would have done to stop the catastrophe that came in South Africa or any of the rest of the countries. And I think it's important to understand that, is that our understanding of the transmission dynamics is actually very flawed, and particularly the social transmission dynamics. I bet you if I went around the room, each one of you would throw out, it's young women, it's people who wear short skirts, it's black people, it's white people, it's gay people, it's sex workers. Everybody has their little stereotype about who gets HIV. And a lot of that actually is not borne out by the data, and I'm going to show you a few examples of that. So what works when it comes to HIV prevention? Well, treatment. If you go into treatment and you're successful, you will not transmit the virus. And I'll talk about that in just a moment. People who are on antiretroviral therapy whose viral loads are suppressed will not transmit the virus at all. We have yet to see this as, in any of the studies that are being done at the moment, and in real-world studies, not just in clinical trials. Mother-to-child transmission has unbelievably successful. In fact, South Africa's rates break down to the situation where our pediatric HIV population is very, very small. We have difficulty doing a clinical trials because there's so few of them at any one time. We had about 80,000 kids born with HIV every year. It's now less than 6,000, which is an amazing testament to this program. Circumcision works. I'm sure there are lots of strong opinions about this, but the science is very clear. It works. It stops transmission and probably it stops people getting it, and it probably stops them transmitting it as well. Needle exchange programs work in most cases. There are some controversies about this, but by and large, they are. For our context, there are very few intravenous drug-using populations within, certainly that I'm aware of, certainly in that circle, but they work, and it's particularly where they're allied to social support programs. Post-exposure prophylaxis, I have unsafe sex, or I prick myself with a dirty needle in the ward. All of those things turn out to be, and the drugs work in that situation. HIV testing is often promulgated as a way of stopping the transmission of HIV, and I don't think there's enough data to show that mass HIV testing programs result by themselves in decreased HIV. I think it's good to know your status. What is interesting is there have been several studies looking at HIV testing, which again, as students of human nature, but you'd probably get this. People who test positive almost always change their sexual behaviors, and they often practice what we call secondary abstinence. They're much more likely to use condoms. They're much more likely to take care of their partner. People who test negatives, they're often behavioral disinhibition. People actually start engaging in higher risk behaviors. And I think that's why sometimes when people tell me about HIV testing programs by themselves being useful, you might actually get damage to negative populations while you're getting the benefits from the positive populations. It's also important to understand that, I'll come back to this later, is that most HIV transmission where we have data, which is largely from the US and Europe, is actually from people who don't know their status. And that's very important to understand, is that people often it's reckless. They didn't inform me that he was HIV positive. I would argue that if he didn't know his status, that's actually even more reckless. And often this ethical thing, which is people have the right not to know their status, I'm not completely convinced that that actually holds. I think that from a public health perspective, certainly in the States, the people who don't know their status are a massive, massive problem in terms of the transmission dynamics and trying to arrest it. People knowing that they're positive has got huge benefits for that individual as well as for the population that they're involved in. Condoms, I put this in brackets because South Africa's got one of the strongest condom programs in the world, and yet we've had we've had condoms for a very long time as part of the old apartheid sort of population control program, but it didn't by itself make a huge impact on the epidemic. And often I wonder if it's because the people using condoms are not necessarily the ones who are most at risk. There are programs focusing on specific risk groups. Now, I think those do work in situations, but you do see how politicians play with this. You see it in Russia, for instance, that a huge amount of the money that's been pumped into HIV prevention programs is going to heterosexual couples, where there's almost no transmission rate. Where you're seeing the Russian epidemic is specifically in intravenous drug use and amongst gay prison populations. And yet, the Russian politicians can't deal with that, so they rather focus the money elsewhere. And you'll see in different countries in Africa, it depends how homophobic or how they feel politically about things, how they actually channel their money. And then, as I said, sorry, I've actually repeated myself, the idea of treatment at the top. I haven't put up here PrEP, because that's a new intervention, but that definitely works as well. Is pre-exposure prophylaxis, before you go into a high-risk sexual situation being put on. Actually, I thought I had it on the slide. I'm sorry, it fell off. I'm not sure why. So we have actually made sex safe, okay? It's essentially true. We have a situation where between two interventions, if you are undetectable, you are untransmissible. I know you guys are going to go through this, but that is the honest truth. You have more chance in this town of being struck by lightning and being killed than you have of contracting HIV from somebody who's on successful therapy. And I think it's important to get this across, because that's kind of these discussions about transmissibility, which freak me out completely, is like, and it's so mired in morality and about intuition and stuff that it does actually need a kind of like an almost philosophical lawyer mind to come and actually put these arguments in front of people. Because I can't see it in my colleagues, they have such difficulty saying, you can go off and have sex if you're on antiretroviral therapy. As long as you know your viral load's undetectable, you shouldn't actually have to worry too much about it. But yet, taking that final little step and saying that is really difficult for them. We also have pre-exposure prophylaxis and post-exposure prophylaxis for people who are negative. And that, paradoxically, is actually slightly less effective. It's still very, very effective than treatment. So we have made sex safe. We just need people to use the interventions and to use them appropriately. And what we've found is that with this, we've seen population level decreases, and this is data from KwaZulu-Natal, where we get lots and lots of antiretrovirals into the system, where we treat people correctly, the HIV in the community goes down, the new incident infection. So there's a huge impetus here for governments to start trying to get as many people on treatment simply to control the epidemic. Because, as I said, once you're on treatment, you stop transmitting, as long as it's successful. How do you package this, though? This is a French advert. I'm always amazed because, like in Africa, you tiptoe around, look after yourself, have safe sex. The French get straight to the point about like what is it. But the packaging of this message is very difficult. And I'm maybe being a bit glib about some of it, but there is something difficult about the fact that people have to take the step forward about the fact that antiretrovirals have the ability to turn people, to completely normalize people's sexual engagements. But it doesn't stop the behavior of change people. I have very little time for this group of individuals because everybody's like, it's the same as in medicine in general. There's a whole thing about prevention. Prevention is better than cure, without acknowledging that actually prevention has a lot of harms attached to it. Whether it's biopsies of organs, whether it's expense and anxiety associated with many of these tests. But here we have these people who are continually talking about behavior change as if it can stop it. And the stuff which has really had an impact on HIV prevention, the stuff I've shown there, has not actually been behavior change. And I'm going to just maybe challenge you with a few of these things. The transmission, who transmits to who and when, is not very well understood, as I said. And because of that, everyone goes with their intuition, which is, as I said, the woman with the short skirt, the black person down the road, the poor person, the ignorant person, the uneducated person, when often that data actually doesn't follow it. Medicine's going through an incredible introspection at the moment, where it's challenging. Doctors, we're taught that we're these little godlike creatures, that everything that we do is actually gotten evidence-based, it's all scientifically based, but actually a hang of a lot of it isn't, whether it's the antibiotics we use, whether it's the interventions for blood pressure. But unfortunately with this has come this internalization of the fact that we know what behaviors are correlated with what. And with sex, it's very difficult to unpack where somebody's bringing their own morality to bear. So we get this message. Edwin told me I had to put exclamation marks around this. is this, when it comes down to it, this is what everyone wants. They want everyone to stop having as much sex, or to have less sex than I am. You know, there used to be this definition of alcoholism is somebody who drinks more than their doctor. And I honestly think that the definition of promiscuity is the same. It's somebody who's having more sexual partners than their doctor. And this idea actually is at the heart of most of the morality around how we deal with HIV and transmission. So this is one of my favorite ones. Men screw around more than women. You know, they have multiple partners. I'm like, how does that work mathematically in a predominantly heterosexual epidemic? There's about 50-50 people, male and female, on both sides of the line. How does it work that men have multiple partners and women don't? So either there's this tiny core of women who are having thousands of partners, or otherwise. So this is the kind of thing that you'll hear all the time when you sit at dinner parties or in the HIV prevention conferences. It's the fact that somebody's lying here. And when you do the data and you ask people, it's exactly what you think. Men exaggerate the number of partners and women underplay it. And that's part of our, the gender roles that happen in here. But people lie about the number of sexual partners. But this, unfortunately, means that women are often given this these sort of empty vessels of recipients of HIV, and men these predatory things, which doesn't actually help the debate. It doesn't help us design programs which are intelligent. The other thing is that concurrency drives the epidemic, which to me is one of the most racist, underlying concepts, and I've published on this repeatedly. But it's like, the reason we're so bad in sub-Saharan Africa is that men have lots of second, third, fourth girlfriends over long-term periods of time. And there's been tons of data to disprove this now. It still has common currency in the HIV prevention world. But we have lots and lots of data. Also, I don't understand why it would be only in South Africa, and Namibia, and Botswana, but not in France or Italy or in America. But anyway, notwithstanding that, we have data. But this continually goes as it's this spontaneous behavior that's only evolved in Africa. And as I said, I'm fairly confident I can show you the science which shows that that's just nonsense. Having said that, something we don't deal with is that people are unfaithful within stable relationships, and that does put their partners. What I love is this is actually a CDC statistic, is that one or both partners are unfaithful at some point in their relationship. 80%. So when your parents tell you they've always been faithful to each other, they're quite freaks of nature. So... You tell me how we deal with this, and particularly in the lawyer world, I'm sure you've all seen this left, right, and center, but the fact is, how do we deal with this? As mature adults, how do you deal with the fact that people are probably sexually going to be putting each other at risk at some point in their relationship, if not one or both of them? And you're probably going to ask me what the gender is. In the CDC studies, men cheat more often on their partners than women do. But interestingly, over the last 20 years, that gap has remained relatively stable for men, but women have got closer and closer. So again, I think, people are people. There was a study, which I can give you the reference for, I should have actually put it here, but showed that 1 in 3 men in stable relationships had cheated over the last 5 years. So there are dangers implicit in these relationships. And from a legal perspective, you need to be aware of this, is that putting somebody at risk by having unsafe, or even safe sex, as I'll show you in a moment, is really important. So one of the things that I had a debate, Olive Chassan is this hotshot social scientist who is completely convinced that the way to deal with HIV is to marry us all off. I'm not married. So she and I had this big debate where in her study, she actually demonstrated that that married women, being married for women, actually posed more of an HIV risk for them than in this study with them married men. But you can understand that, if you're married, why would you use condoms? You're abstinent. You shouldn't be abstinent if you're married, obviously. Be faithful. You can be faithful as you like if your partner isn't. And people don't use condoms in long-term relationships, let alone in marriages. So all the big ABCs, the big primary things we've pushed to promote HIV prevention, didn't affect a group of people which is a high-risk group, which is married women in South Africa. Again, for me as a public health person, this becomes really difficult to try and work out how do we get some safe sex stuff to them. And it's not easy. So I like this quote from somebody at my university. She's a professor of ethics. And she said, where health advice is not based on actual evidence is likely to give expression to individual and social
intuitions. And these frequently seem to express Calvinist, moralistic ideas about how we must be improved by self-denial and suffering. And I paraphrase this. It was a guy from the head of health in the US. And he said, public health is all about not enjoying your food, not enjoying your alcohol, and not enjoying sex. And I think there's something in that. It's like you must deny, deny, deny. And I think it does come from for many of us from our religious heritage, which is denial, denial, denial. And I think with HIV, this has been a subtext which we've had to deal with repeatedly. So I just want to put some of the stuff that comes out often. So the first thing is, these were some areas. So the first one there in the left-hand corner is mobile men with money, what we call men or blessers. You know, rich men, young women, big power dynamic, they don't need to negotiate condom use, they're going to spread HIV. The second thing is that young women are driven by all those C's, cash, cars, clothing, cell phones, that's the other one, all the C's. It depends how many C's you can come up with. The other one is that, is this idea of age discordance. When you're a much older man, there's much greater risk, actually, to young women. And then the top one is about the concurrent partnerships. Now, the interesting thing is that we have absolutely no data to suggest that there is a risk between men giving gifts to young women and HIV. We all creeped out by the fact of these creepy old men having sex with these much younger women. But for the HIV debate, there actually is no data to suggest that this is true. The same goes for these Cs. Now, I cannot believe, sure, there were no cell phones 20 years ago, but you cannot tell me that young women in those days, that there's something much more acquisitional and different about young women today than they were 20 years or 50 years ago. Like, what's changed? And I'll show you a quote in a moment that kind of is, what is interesting though is that for the concurrency, we actually have data to show that there's no link to the concurrency stuff. So where we actually did measure concurrency, there was no risk attached to it with HIV. It doesn't stop the HIV prevention field continuing. And then my favorite study about the older men was a study done in KwaZulu-Natal about 3 years ago, which showed for slightly older women about between the age of 35 and 50, if your partner was much older than you, you actually have much less HIV. So you should go and get a sugar daddy as a way of actually getting less HIV. I actually said that to the minister because he's been going on and on and on about sugar daddies driving HIV, and there's all these big billboards in KwaZulu-Natal saying, sugar daddies are bad. And I said, no, now we've got data. Now we must put up big billboards saying sugar daddies are good. Now, obviously, I'm being glib again, but I do think that this just demonstrates to you the bizarre morality that, as I said, that we're all creeped out by creepy old men going out with younger women. But we mustn't let that obscure the fact that that's actually not the science of HIV transmission. So, I just love this quote. So we constantly, when I was a kid, it was all about you kids, you play computer games, you watch too much TV, and it's all these things that, it's modern relationships, pornography, concurrency, video games, promiscuity, drug use, degradation of respect, sugar daddy, single day. This is why these young women are at so much risk, is because they're not like our parents were. So this quote, our youth now love luxury. They have bad manners, contempt for authority. They show disrespect for their elders and love chatting in place of exercise. They no longer rise when elders enter the room. They contradict their for company, gobble up their food, and tyrannize their teachers. So that sounds like something that, this year, 400 BC. So I think what we've got to understand is this is pretty much a characterization of being young rather than. And this book was fascinating, is just how people just reinvent history about what they were like. And I think back to my childhood, we did stupid things as well, and just survived them for reasons that are not always apparent to me why. This study was really interesting as well, which was from our unit, which demonstrated everyone's like, okay, again, the racist subtext is that young black women just have so much sex, and young black men are just so hypersexual. They showed actually, these are very difficult studies to do, but they showed actually the number of sexual partners and the kind of sex people were having in Africa was much lower risk than in Europe and America. Yet the HIV rates are several thousand-fold greater. So there's something here that's not about behavior. There has to be something else that's going on. I'm not saying that behavior is not associated with HIV for a second. I'm just saying that we don't seem to understand it particularly well. So what I love to talk about, so we run a very large sex work program and have done for the last 2 years. And I've had to, my own intuitions about sex work have been challenged left, right, and center. But it's illegal in South Africa. We have huge police harassment. And we have these two extremes in sex work. And on the one hand, we have the sex work is absolutely fine. Everyone should be able to do sex work and just get on with it. And the other extreme, which is far, far more common, which is sex work's illegal. We just need to clamp down harder and harder and harder. And then there's this weird in-between zone, which is actually much closer to the second one, which is like, let's criminalize the clients, but let's like not criminalize the sex work, which is the stupidest idea I've ever heard of. If you were a drug dealer trying to sell drugs, like you say, oh no, I'm going to criminalize the client, what's going to happen? The client's going to still make their way towards you, but they're going to do it. And what we're seeing with these kind of models is this almost, within the programs that we're running, is that people trying to deal with their own internal morality, when what we're trying to do is to deliver a public health intervention for sex work. And what it's playing out, certainly in South Africa where it's illegal, is that the police harass the sex workers, they arrest them, they put them in prison, they rob them, they rape them, they do all sorts of terrible things. And the clients are filled with shame and therefore don't come forward and say, like, I am now purchasing something. So what we've done is create this bizarre market, which is just guaranteed to drive HIV. And I think for the legal profession, it's interesting to reflect on those, like, why is sex work illegal? Like, what are the reasons behind it? And to my mind, when you come down to it, it's an entirely moral thing. I'm not saying that sex workers aren't harmed, that they're not within their profession, and that there aren't real risks attached to what they do. But you can argue that about mine workers. You could argue about that about truck drivers, about police officers. It's about how do you protect people when they're doing something that's implicitly dangerous as part of their job. Anyway, that's a nice, big, long thing. But the interesting thing is that by making it illegal, you force people underground and not to, oh, I'm being told I've got no time whatsoever. Anyway, the same thing goes about gay men, that in countries where it's illegal, and in the past where it's been held, we've seen places where stigma is high, where being gay is still not acceptable, and that includes big chunks of places like the United States. It's an independent risk factor for HIV acquisition. And again, it comes down to the fact that this morality, this subterfuge, actually undermines our most basic HIV prevention pattern. We've now got amazing data from America, from Europe, where PrEP programs have been rolled into programs for gay men, demonstrating dramatic decreases in HIV incidence rates. But it's only in places where people are not ashamed of their sexuality. What about drug use? Again, people don't like drug users. They don't like, the kind of, again, and it plays itself out into both the legalization stuff as well as the fact that these needle exchange programs, which you have to roll out in a place where people feel safe, actually work. In Amsterdam, about 12 years ago, they had 10,000 heroin addicts. And they've got less than 1,000 at the moment because they have a needle exchange program that's attached to social support and all sorts of support factors for mental health needs. I'm not going to talk about drug use at the moment. It's still uncommon in our area, but I think it's coming. We're certainly seeing in Johannesburg the first signs that there might be more intravenous drug use than we thought initially. But the important thing about all these groups is most HIV transmission occurs within straight people in long-term relationships. It's not the sex workers, it's not the gay men, it's not the druggies. It's the people who are like wandering around, going to dinner parties as couples. And I think that's the stuff that scares me still, is that there's this incredible, in America and Europe, there are subgroups which you can easily compartmentalize. Part of our problem in Africa is actually the fact that it's everyone, and that the risk is often, when I say Africa, sub-Saharan Africa, and certainly in Northern Africa, it's very much a gay epidemic. But in this town, it's very much a heterosexual one. So I'm going to end off with the last two things. I think that health is an amazing opportunity for human rights work. I think that there's an agreed ethical imperative around it. People are happy to give resources to health with good reasons. Too much, there's not enough interrogation of those resources over things like job creation and housing and things. But I think that it's useful to use it to grab. I also think that HIV is very useful as a proxy for overall healthcare. We measure it well. We know we've got interventions that work. As opposed to diseases like malaria and schizophrenia or depression, these things are very well put together and are very well monitored. One of the things I get frustrated with is how much money African governments actually spend on their healthcare system. There's always money for soccer stadiums and guns and elections and, but when it comes to the actual health systems, very few of them are actually contributing what they should be in terms of what WHO says they should be in terms of their gross domestic product. So I think HIV has done a few things. You'll be happy is my last slide. I think we've seen unprecedented resources mobilized for HIV, and what's gone with it has been impact on life expectancy, on quality of life. We've stabilized families across the region in not enough, but it's really been unbelievable, the advocacy and what we've managed to achieve with this. We've also, as you can see, we've made evidence far more central. It's not that intuition is constantly challenged, not as much as I'd like, as you can hear, but there is a situation where people are being told, show me the evidence. HIV is a new disease. Everything that's ever been done there, every decision about a treatment program is on the internet. We can see the history of where it came from because it's such a new disease. We can't see that with diabetes, with tuberculosis, with many other illnesses. Sorry, I'm brilliant. I think we've got sex out into the open. I can honestly say that certainly when I was a child, we did not talk about sex the way we do at the moment. And that's across the board. In the most conservative societies, we've been able to talk at least frankly about it. Not always without judgment, not without the morality and all the rest. But our current president of the country has come out to say he wants sex work decriminalized because he wants X, Y, Z. You know, our previous presidents all got up and tested up. And I think that this has been much better for the society because it's also stopped some of the hypocrisy that's been going on. I think we've focused attention on a whole range of things, like how much money we spend on what, and then on things like patents. I think that certainly in the HIV world, we've been unbelievably successful in terms of challenging patent law and getting drugs, the best drugs of all. In fact, there's a possibility that in Johannesburg, you'll be able to get drugs that you won't have access to in London or Germany or New York. And that, I think, is testament to the activism that's gone through it. And my last thing is that I do think that we've put human rights front and center. And we can often think that there's been pushback, but if we had been stuck where we were 20 years ago, I can guarantee you that the kind of homophobia, the kind of debate around sex work, the drugs, patent laws, and all the rest would not have been front and center if it wasn't for HIV. And I think that we have a lot to thank for the entire activist movement around it for starting to push back boundaries, not just within health, but across the societies we live in. And I probably should stop there. I think I've got...
Thanks, Francois, for that incredible overview of HIV and science, public health and policy. It's unbelievable. So I thought what we'll have a conversation. Is this working? Yes. We'll have a conversation aided by PowerPoint to help us focus on the science of HIV in the context of criminal law. I just wanted also to, Edwin Cameron mentioned the impact of antiretroviral therapy on his own life, and just wanted to point out as well, I acquired HIV in 1983, diagnosed in 87, finally achieved an undetectable viral load in 2002, and here I am. And I don't have before and after photos, but and I think one of the key issues that we need to talk about, there are three in the context of the criminal law for science, and that is harm of HIV, the risk of around acquiring HIV, and then how do you prove that one person passed HIV on to another or not. And I think it's to start with the harm, because the reality is there are no other diseases that have laws specifically for them. And in my presentation yesterday, we highlighted that there are either 29 or 30 countries in Africa with HIV-specific criminal laws. And there are, even where there aren't, so here in South Africa, there was a fantastic work done by Edwin Cameron and others, Zaki Akhmat and others, to prevent there ever being an HIV-specific law here in South Africa. But it has been treated as attempted murder. And so why do we think, how can we use science to talk about how is HIV not as harmful as the law seems to think it is anymore? And how do we talk about this in a way that doesn't suggest criminalizing other transmittable diseases such as TB, which of course is the other communicable disease on this agenda, but or other sexually transmitted infections. How can we contextualize the lesser harm of HIV in the context of antiretroviral therapy without unintentionally suggesting, well, you know, let's criminalize other diseases. It's a shame that we don't have two microphones, because a conversation without another microphone is a bit difficult. I think, I mean, maybe Francois, if you want to come and sit here, and then I'll just pass the mic back, we'll pass it backwards and forwards. And then hopefully.
We'll get one more.
So let's talk about harm, and like, I mean, how you were saying that you would rather have HIV than TB. I mean, how harm? I mean, but we're talking about HIV in the context of access to antiretroviral therapy, to lifelong, good quality, affordable antiretroviral therapy. And in Southern Africa, how realistic is that for most people?
So it is quite country specific. I mean, I don't want to, I'm quite nervous of saying it's just like any other disease, because I don't think that's true. And you're somebody living with HIV, I think it's not for me to speak on your behalf, but when I listen to my patients, there is stigma, there's shame, there is a whole range. There's just the fact that you've got a chronic disease and you're swallowing a tablet every day, you know, is something that is, I'm wary of just pushing that aside and saying, just get on with your life and it's all fine. Because I think there's a complex psychology to having a chronic disease, which I think we mustn't undermine by trying to pretend that this is just like anything else. And I sometimes do see that happening, and I do worry that we undermine. The harm that you're talking about is very, from a health perspective, is actually extremely limited by the looks of it, I think. The drugs that we've got are so safe, they're so readily available, they're very cheap, even if you're in the private sector. They're free in most government access programs. At the moment, where there's a fair amount of funding available for it, the chances are that if you're just willing to acknowledge you're HIV positive, you'll be able to find a treatment program and you should be fine in 95% of times. The other 5% of times where there's complexity to your treatment, there's side effects, there's some other thing that's going on, usually that's fixable. It just needs a healthcare system that can handle it. I don't know if that answers it quite well.
Yeah, I think it's a really good start, and I think that really what you're saying is it's the stigma in lots of ways, whether it's internalized, anticipated, or enacted. And of course, the ultimate enacted stigma is HIV criminalization. And I think, I mean, that's really what stands out around HIV these days, is that it's, despite the incredible advances in HIV science, it remains stigmatizing, and that's the reason that, you know, that the HIV Justice Network and my work focuses on trying to remove HIV criminalization, because whilst laws are on the books and the prosecutions keep happening, it's a vicious circle of stigma, as Richard's slide earlier highlighted. So, in my presentation yesterday morning, I talked about that there were there's been some fantastic guidance on how we should tackle HIV criminalization. And this is the most recent guidance from UNAIDS, ending overly broad criminalization of HIV, non-disclosure, exposure, and transmission, critical scientific, medical, and legal considerations. And I just thought I'd go through these, and then we can talk about exactly where the scientific and medical considerations fit in, and your interpretation of those. So, the top line recommendation, restrict the use, if any, of criminal law in the context of HIV, ideally to intentional transmission only. And we'll talk about that specifically a little bit later on. Where it is used, where the law is used, criminal justice principles, including key criminal law principles of legality, foreseeability, intent, causality, key one for us to talk about. Proportionality and proof, another one for us to talk about, should be upheld. And the best available scientific and medical evidence should guide any use of criminal law. We should treat like harms alike with proportionate penalties. Condoms or low viral load, note it doesn't say undetectable, and we'll talk about that in a moment, means no significant risk. And the use of condoms or being on treatment or having a low viral load would show no intent to harm. Non-disclosure alone is not proof of malicious intent. Now that's a state of mind issue. We don't need to talk about that in the science part. And of course, it highlights the limitations of scientific tests for use in HIV forensics, such as phylogenetic analysis and recent infection testing algorithm known as RITA. And we'll talk about that in a bit more detail. So let's start with what I think started it all in terms of the global dialogue on the impact of treatment on transmission risk, which is the Swiss statement that was published on February the 1st, 2008, that says people with an undetectable viral load with no other STI cannot transmit HIV during sex. This was had a huge impact. I was the author of the NAM AIDS map story. It blew my mind at the time. And it was incredibly controversial and remained controversial until a number of incredibly powerful studies, such as HTP N052 and the partner studies, actually showed that this was true. And we can also talk about whether the no STI, the no sexually transmitted infections, actually is relevant based on the data we've seen from the partner study. Now, the reason this statement was written in 2008 was because in Switzerland, people were being prosecuted for having consensual, condomless sex, despite there being no transmission risk. And people were doing this because they either wanted greater intimacy or because they wanted to have children. And despite there being no risk and no transmission, one of the laws in Switzerland actually allowed prosecution to happen, and people were going to prison. So this statement was written primarily to prevent that happening. And it did have an impact. The Geneva Court of Justice the following year actually recognized the Swiss statement, and that led to actually huge changes in the law in Switzerland. Fast forward to 2014, it took that long for there to be another consensus statement, and this is actually the most remarkable, I think. The Swiss statement is incredible, but for the context of criminal law, Richard's in the room. I won't embarrass him by talking about how amazing this is and what a model it is for future consensus statements. But in Canada, I can't remember if Richard explained this in his talk this morning, but the issue, the factored issue constantly is around whether there was a realistic possibility of transmission or a significant risk prior to the maybe or decision. And Edwin Cameron yesterday highlighted how the Supreme Court of Canada got it so wrong in 2012 when they actually were presented with evidence that treatment is prevention and that that either treatment or condoms could negate criminal liability if you didn't disclose before sex. They ignored that, and they actually ruled that you needed both to be on treatment and have a low viral load and use a condom together. And that is the state of the law currently in Canada. And this is why a number of very prominent Canadian physicians got together to produce this consensus statement. And this talks about risk the risk of transmission in a very different way than we're used to. The public health messaging over 30 years has been, something's high risk. Anal sex without condoms is high risk. Vaginal sex without condoms is high risk. And then there's, maybe they talk about medium risk. I'm not even sure. Maybe oral sex was medium risk and kissing is low risk or something ridiculous. And this reframed reframed it, because what the courts need to do, and not just in Canada, but in many cases, actually look at what is the per act possibility of someone being exposed, never mind of transmission happening, but of someone even being exposed to HIV. And they reframe this as low, negligible, and zero. And zero risk, of course, is on effective treatment, or consistent use of condoms. I can't remember what negligible, what was the definition of negligible, Richard? Can you tell us?
So one thing that was important in this statement was to define each of the categories of low risk, negligible risk, and no risk, so that those categories could then be applied based on the science available as of 2014. To different sex acts. And so if I recall correctly, and I'd have to double check, sex with a condom, for example, penetrative sex with a condom, there's an explicit statement in there that an unbroken condom is 100% effective in blocking the virus, which is very important and has been used in subsequent cases. There's a description, I think at the time when this was put out in 2014, we said that the risk was negligible if someone had an undetectable viral load. There's obviously been some additional science since that could probably strengthen that statement in future iterations. Oral sex was described as negligible to no risk, if I recall, because you couldn't rule out theoretically the possibility of transmission through oral sex, but it also noted that there had been very little evidence to show that this was occurring. So because you left open the door to a theoretical possibility, you couldn't say zero, but it was described as negligible to no. And so since the legal threshold that had been established in the law was that there needed to be a significant risk, the point was to establish that on a per act basis, most things don't rise to that threshold.
Thanks, Richard. And the main reason that a consensus statement is required, it's similar to the Swiss statement, is that because often the person who's acting as an expert witness is not necessarily on message, or is not, or as you talked about, maybe have other moral ideas about, it gets mixed into the case. And it's important that, especially given the controversy around the Swiss statement and the impact of treatment on transmission, that there was a consensus statement and Canada did it first. Now, there have been a number of consensus statements since. Sweden did one in 2015, and the Australian one is the most recent one of 2016. What's interesting about the Australian one is that it followed the Canadian model and talked about risk being low, negligible, or zero, and this time zero was low viral load, but also added in other issues, including, for the first time, PrEP, talking about the adding PrEP as an effective HIV prevention method, and then talks about proof and the impact, the limitations of phylogenetic analysis. And so let's talk a little bit more about per at risk, because lots of people talk about willful transmission. And in fact, that's the name of many of the statutes in Africa. They're known as willful transmission statutes. They're very vague. Now, let's just talk about how easy, if you wanted to infect somebody with HIV sexually, how easy is it to do that? If you really wanted to do that, how many times would you actually have to have sex with someone in order to willfully transmit HIV? And how does that fit into how you think the courts and the general public perceive how easy or difficult it is to transmit HIV sexually?
It's actually really difficult. The only way we definitely, 100% transmission is actually with a blood transfusion. When I did the risk assessments for some of the suggestions you're talking about, somebody who's not on antiretroviral therapy, who's in post the acute seroconversion phase of the first few months, the transmission risk, if they don't have an active sexually transmittable disease, is one sex act every 10,000 acts, which is sex every night once every 27 years, which is just saying maybe I'm TMIing a little bit. That sounds like a lot of sex to me. But that is what the risk establishment was. The original thing was in somebody who's in the plateau phase of HIV, which is usually when people are detected. So if I wanted to go and deliberately infect somebody, there would have to be either a lot of violence associated, which there's blood involved, and that's why rape is a high-risk act. It does increase the risk, but even in that situation, it's only a very small minority of transmissions that will happen. Even receptive anal intercourse is only a small, I can't remember the exact number, I think it was 1 in 80 was the number that was tossed around. So you have to have sex 80 times before you have one, on average, to contract HIV. So I got into a lot of trouble in the radio program for saying oral sex is safe sex, because in fact, if you look at the numbers, condom sex is more dangerous than oral sex in terms of transmission risk. But yeah, the field has such difficulty quantitating this issue. So your short answer is to actually deliberately infect somebody is very difficult unless there's huge amounts of violence involved, or that you actually inject them with your own blood directly into their bloodstream. And even with blood transfusions, there have been a few cases where transmission hasn't been documented. So even that's not absolutely foolproof.
You are the ideal expert witness, Francois. Thank you. Yeah, and in fact, of all so you probably don't know this, but what we do is we track every prosecution that we know about. And in terms of willful transmission, deliberate, malicious transmission, I would say they've been proven beyond a reasonable doubt in courts maybe a dozen times, and yet we've had thousands and thousands of prosecutions. And a number of those have actually been HIV negative people who've had access to the blood of someone with HIV who has injected it into someone. There it's pretty clear that there's a deliberate malicious act. But just having sex without disclosure, even without being on treatment, and I think obviously we need to talk about the state of mind of proof, which is nothing to do with the science, but even if you wanted to infect somebody, it would be, or to harm someone, it would be easier to hit them over the head, stab them, shoot them. And a lot of the laws used make an assumption that in fact having sex with someone or that someone with HIV is a lethal weapon. And it's great to hear that you agree with that. And more expert scientists, of course, not only agree with that and understand that, but actually are beginning to appreciate that this is what needs to be said. So there will be a globally relevant consensus statement on science in the context of criminal law that is likely to be published and released by AIDS 2018 in Amsterdam. And the hope is that this will not only, there are 20 expert authors with global renown, but also from all over the world. And we also hope that once it's released, that leading scientist in every country will endorse this statement, so that it will start to normalize what an expert witness says around risk and harm, and also proof. So let's move on to how do you prove that one person infected another. So this is a paper that I co-authored with a number of phylogenetic experts and policy experts back in 2007. This was right after the very first time that the limitations of phylogenetics had been espoused in a criminal court, at Kingston Crown Court in 2006 in England, where for the first time Anna Maria Goretti, as the expert witness, highlighted the limitations of phylogenetics. Until before then, the police and prosecutors, even some of the defense attorneys, believed that if two viruses matched between a complainant and a defendant, then that was proof, just like fingerprints or DNA, that one person infected another. And Dr. Goretti, we watched her on the stand being grilled for hours, cross-examined. So this person who was accused was found not guilty, was directed by the judge to be found not guilty. So we wrote this paper about all the pitfalls and acceptable standards in the use of phylogenetic analysis as evidence in criminal investigations. And whilst there have been other papers written since, this is a really good background paper for anyone who wants to understand the limitations of phylogenetics, because although the science of phylogenetics has perhaps improved, particularly for public health purposes, and in fact that's what it's been developed for. Phylogenetics is looking at how does HIV move among populations in order to be able to figure out how to do prevention or where to target funding, whatever. But from a forensic point of view, this is still very much in its infancy, and there are very few experts in the world who actually understand exactly what you need to do to do this effectively. So just very briefly, what you really need to do in order to be able to prove that one person infected another is deal with various issues, including fact. What could this person who's claimed to be infected by the defendant have been infected by someone else or in some other way? So that requires a medical and sexual history. Then you need to look at the timing. Is it possible that this person was acquired HIV before the other person that's accused actually knew their status? If they've been in a long-term relationship, maybe this person acquired HIV relationship and only got tested halfway through. And then there's the issue of direction, who infected who, and science in and of itself cannot show that. There are huge limitations to phylogenetics to show that. So as I say, unlike DNA, it's unable to create a definitive match. And you can ask, are the viruses related? And yes, well, that adds to the evidence. It would be consistent with the theory that the defendant was responsible for the complainant's HIV. But in fact, where phylogenetics is really useful in HIV forensics is showing that the viruses aren't related. And if that's the case, then of course the accused is exonerated. And this is not done in very many countries because A, the expertise is very limited, and it costs an awful lot of money to do phylogenetics for forensics. I just show a pictogram that really highlights why phylogenetics is limited in showing, even when the viruses are really similar, just as with TB and the tree that we saw earlier in the phylogenetics, just because the viruses are really similar, the analysis could be missing out key individuals. So in this case, if A is the defendant and B is the complainant, there's also the possibility that there was an unknown person that could have infected of them, or that there was somebody in between, or that there's actually more than just a C, there's a D, which involves understanding sexual networks and making sure that when you're actually doing phylogenetic analysis, you actually include the virus of other people in the same sexual networks. Otherwise, you're not going to be able to capture similar viruses. Now, I know that's probably a bit too complex, and I don't know, Francois, if you're able to make this any simpler or explain in any better way why it's really difficult to prove who infected whom.
I actually don't. I think you've explained it beautifully.
I do think the technology is improving from what I understand. Edwin, you probably have more knowledge about this than I do, where they are able to like talk about transmission in a little bit more like the actual being able to prove it. I'm aware of it's an interesting thought experiment, is that particularly in a small contained epidemic, and I know this thought experiment's happening because I was asked for my advice on the case, in one country where they actually are storing samples from individual patients, being able to trace, they think, who infected who. And what does that do for your legal situation? And I don't have easy answers for that. All I know is it is a recipe for litigation and for blame and stigma and goodness knows what all. And I think that's where your privacy laws actually need to kick in big time, because I think that has the ability to do huge amounts of harm. And as you say, I think this idea of being able to exonerate, it's very simple to explain. It's the same as with pregnancies. That's not the father. Is like the easy way with these tests. These tests have become more and more available as they've got cheaper. So I think while it's very expensive at the moment, those costs probably will come down, and which is what happened with the pregnancy tests. And I think we just need to anticipate this is a legal issue you guys are going to have to grapple with, which I think is possibly fixable, but needs a very cold eye on it just to keep it from further fueling stigma and blame and all the rest of it.
So yes, there are phylogenetic experts, particularly working in the United States really on the public health side, who are coming up with new technologies that appear to at least be able to show direction. But one of the things that we need to be clear of, certainly as defense lawyers, and those who are activists, is that these tools are developed for public health purposes, and that to be able to replicate this for forensics is actually untested. And some of these experts have been called in cases in the United States. In the US, doesn't really need to prove transmission. Nearly every state doesn't need to prove transmission, apart from in Texas. So it's been used a couple of times in Texas, and there are other experts in phylogenetics who disagree with their techniques and with their conclusions, and so there isn't complete consensus on the new developments, and so it is better to be cautious and to say that currently there is no HIV forensics technique to show that one person infected another. So I think I just wanted to highlight that all of this, all of the guidance, all of the information about phylogenetics, everything about science is in our HIV Justice Toolkit. I gave a shout out to it yesterday. You can basically, it's HIVjusticeworldwide.org, and you click on Toolkit, or you just write toolkit.hivjusticeworldwide.org. You can find everything that's ever been written around HIV in the criminal law, the science, the policy, all the guidance, all the consensus statements, it's all in there. And you click through, and there's using science to prove your argument. I'm going to just leave this slide up, which is basically our website, the HIV Justice Network, which has got all the latest news, cases, all that kind of stuff, and then the HIV Justice Worldwide website. You're also welcome to join the movement. But I'm going to leave it there because I'm sure you have a billion questions for Francois and maybe for me. So thank you.
That was a lot of information, and I don't know how many have been able to digest all of it, but I think we probably have questions. I know some may not be related to HIV criminalization, which is fine, and that's part of the learning opportunity. So we open it up for any questions, comments. The shorter you keep them, the more we get more questions, the more we have a conversation. And please let us know if you're directing your question to Edwin or Dr. Francois after there are two presentations and conversations. Nothing legal here, no sections were mentioned. It's purely science. I would like to see by a show of hands so that we go by one round and then go for another one. So there's one hand, that table, number 2. Number 3, you're doing well, you'll get an award for questions. Number 4, anyone online? So we start with those 4. Go ahead, your name and the person you're directing your question to.
Hi, my name is Ayanda from Weber Wenzel Attorneys. So first, I'll just confirm Edwin's statement that Dr. Venter is the ideal witness. I worked with him in the Gary Allpass case, if he remembers it, and he was the expert witness in that case. And I think the court was heavily indebted to him for having taken the court through the science of HIV. My second, so that was a comment, but my question, Dr. Venter, is I'm starting to see a trend in the increase of TB discrimination in the workplace mainly. And despite the education that has been, the education that's there are a lot of cases that are rising now on TB discrimination. So I just want to find out from you what can be done in that context. Thank you.
Number 2.
Hi, my name is Kuziva Kwashe from Zimbabwe Lawyers for Human Rights. My question is for the good doctor there. You indicated that a person with an undetectable viral load cannot transmit the virus, but maybe I will need some clarification. Say if somebody tests HIV positive, and then at some point in their life, they have an undetectable viral load, does that mean if you do a home test, they'll test HIV negative?
Number 3.
My question is one of those that falls in the category R and says they're not criminalization of HIV related. I wanted an explanation on what you said that women between the age of 30, I think you said if they date older men, they have a lower risk of getting affected. I wanted an explanation on that.
You're looking for permission, aren't you?
I hope those are not judgmental giggles. Remember, we're not being judgmental.
Why that is the case. And my second question is there anything as HIV drug resistance? Yeah.
Number 4.
This question goes to Dr. Venter, and I think also to the other speaker. No, actually to Dr. Venter. What is a question that you have often received as an expert witness from the court, which you find that the court or the lawyers don't understand? And then secondly, you've mentioned the right to privacy, where the right to privacy laws will have to kick in, especially when divulging information about patients. And I wanted to know from the doctors' professions, like, do they divulge? Is there like a doctor's ethics or ethics of doctors and medical practitioners not to divulge information of patients because of privacy laws? Then what happens if they are given such warrants? How do those two conflicting issues get answered? Thanks.
Great. I don't think we had a number 5. Did we? That's rigging, but that's okay. Number 5. First time that table is asking a question.
Okay, my name is Edwin Bernard from Liberia. In Liberia, we don't so much have the situation of criminalization because our law is very clear that to accuse a person, you have to prove beyond all reasonable doubt that the person, committed a willful intent. But the major issue there is the situation of stigmatization, which I would like Doc to please throw light on how he handled the issue of stigmatization during his experience as a public health person.
Well, surprise, surprise, Francois, you have all the questions, all 5 of them.
Edwin's help on some of them. So, your question about TB, the TB needs TB Action Campaign. They're ready. The mic is not on. Sorry, Mike. The TB world needs activists. They desperately need help. TB, honestly, has been underfunded. It's been underrated. It's been run by a cartel of elderly men who seriously have tried to do as little as possible with the least amount of money. And it is shameful indictment on public health. But it's also an indictment on the legal profession, on the public health profession, on my profession, at how little actual success. The HIV world would never put up with the kind of stuff that the TB world has put up with. The problem is that people with TB are much less able activists than to advocate for themselves as well. So I think there is room for that to happen. I think it's starting to happen, but it's taking a long time. But the drugs we use, the diagnostics we use, the way we treat people with TB is shocking to my mind. Even if the language that you hear is TB suspect, defaulter. You know, never talk about an HIV suspect, you'd get like roasted. Your question about testing HIV negative if you've been on treatment for a while, if your viral load's undetectable, is a very good one. There's a lot of debate at the moment. A lot of our tests don't come out as strongly positive as they were once you've been on treatment for a long time. So particularly with the oral tests and with some of the rapid tests, the line just comes out, it becomes much fainter when you've been on treatment for a long time. So try to tell that to patients they're not negative. The test is just not as good as it should be. And there's a lot of, certainly in the last 3 months, a lot of attention to this coming forward. So it's something to maybe watch this space. The question about how is it possible that young women can be at lower risk when they've got older partners? It was interesting. I was at the session where this presentation was put forward, and it's a complicated paper, and it's one paper. I'd be very reticent to simply take this as gospel. But we had anthropologists in the audience. So if you're below the age of 35, a young woman below the age of 35, and your partner's 5, 10, 15 years older, there's no change in your risk. You've got a risk, but it stays the same irrespective of the age. When you're older than 35, if your partner gets older and older and older, the risk goes down. And if your partner's more than 15 years older, your risk was half what it was if your partner was the same age as you. So that's why I'm being glib about you should go and get yourself a sugar daddy if you're over the age of 35, because you've got much less chance of HIV. But the anthropologists in the audience were saying, they came forward who were involved in the study, and there was a big like blah, blah, blah at the front. And they were saying that when they went and did interviews with these women, they said, firstly, there was less sex because the guys were older. The sex was gentler and there was less alcohol involved. Now that actually does make sense. When you think about it physiologically, there's less sex acts, there's less risk, there's less violence, there's less alcohol involved. All of those things together, and they also said the sex was much better. Now, for that reason, you can actually come up with a plausible scientific information as to why having an older partner is actually protective. So all I'm saying is, again, the morality doesn't fit with the creepy old man. But the fact is there actually is plausible science behind that. I mean, those are just hypotheses. They're not proven. But it does kind of, that makes sense. As I said, it's one study. I'd be very reticent to accepting this as being plausible, because there are other studies showing that age discordance is an independent risk factor for HIV. How you make sense of all of this, I'm not sure. But it's not as simple as wandering around saying, just say no to older men. And in fact, I used to give this as one part of my risk-taking talk about 15 years ago to our Department of Medicine. All these old professors were looking very uncomfortable because they all had much younger partners. And now I realize I was part of fueling the stigma around HIV as well. So just on drug resistance, these new drug resistance, HIV drug resistance is a very rapidly evolving field. The new classes of drugs that are going to be implemented in the next 2 or 3 years have very, very, very low resistance potential, if any. So I think that is, again, watch the space. We'll have more data once we've had these programs rolled out for a couple of years. It's a big problem at the moment, certainly in sub-Saharan Africa. But the new classes of drugs might actually make that problem go away, or we hope that they will. So just watch the space. Life expectancy, and you asked about the courts and what the commonest question is. The commonest problem I have with the judges when I'm presenting is they think everyone's going to be dead in a year. Honestly, I go to case after case after case, and they're like, this person doesn't need retirement in year 2 because they're going to be dead soon, so it doesn't really matter. And all I do is keep putting this up and say, life expectancy 81, and that changes their minds immediately. So you ask the commonest problem at the court level, it actually is both from the legal side, the lawyers, as well as but mainly from the judges, because they often tend to be older. They just haven't engaged with this, so they're just not up to date.
The right to privacy and to divulge to a third party. So medical, certainly in South Africa, and I'm sure it varies dramatically from country to country, but in South Africa, you have to demonstrate that a third party is going to be harmed if you are going to divulge. So the way it was explained to me by a philosopher, ethicist, said there's two scenarios. There's a young woman in front of you, she's HIV positive, and you say, I need to tell your partner, because she says, I don't want to tell my partner. You say, but you need to because you're going to harm your partner. And she says, no, my partner beats me all the time. Like the commonest cause of death, the commonest murderer for women is their intimate partner in South Africa. We know gender-based violence is terrible. So she stands in front of me, she says, my partner's going to hurt me. He might even kill me if he hears I've given him HIV because he's going to presume I gave it to him and not the other way around. As a doctor, I cannot disclose to that partner because she's given me a plausible information. However, the story differs if she says, I'm in this marriage, I don't really like this guy at all, so I'm not going to tell him, and I'm going to go home tonight and have as much sex with him as possible so we can actually transmit the virus. That is a very different debate and a way of dealing with it than the previous scenarios. You actually do need, as a clinician, to use your brain. You know, it's like, if this is a plausible story. Also, in terms of disclosure, where do you stop? Do you stop with the immediate partner, or do you go and find every boyfriend and wife and everybody else that you've ever had sex with over the last 20 years and tell them? It's not actually practical. So in my experience, most people do disclose to their partner. We've actually done studies on this in central Johannesburg, where 90% of people tell their partner within a year. They just need time to get the information across and processing. And often just being supportive helps that process. The last thing was about in Nigeria and about, I didn't quite catch the question. Sorry.
It was the question from Liberia asking that how do you deal with the issue of stigma, if I got it right.
Sorry, what was the question?
How do you deal with the issue of stigma?
I think it's very complicated, and I think that's not as simple as saying we're all just going to get along and everyone hugs somebody with HIV and it's all going to be fine. I think it's much more nuanced than that, and I think that you need to interrogate language. I use language very casually, as you can tell, but sometimes just the term infected, for instance, has a huge consequence for the person who has HIV. And you know, as a medical professional, we just talk about HIV infected because that's the way we think. But I've realized for a lot of my patients, that's actually not a great term, and it actually is stigmatizing. And you'll see that there's this, often criticized as being politically correct, but the language of being HIV positive is what people talk about now as being the language that they prefer. In the medical field, that doesn't work very well, and as I said, things like TB suspect, you can see why I'd be really angry if I had TB and I was being investigated for TB and I get called a suspect. You're completely criminalizing something when I'm actually the victim of gross negligence on the part of everyone who's supposed to be looking after me. So again, I think just being more aware of it, and like I said, that dinner time conversation was a case in point. I had two people, a couple sitting across from me with HIV, while the other side were like venturing forth about how people get HIV and their pet theories as to morality and why people have too much sex and they just let themselves go. And this couple sitting right in front of them on ARVs, completely healthy, you wouldn't know anything, but just assuming that they're HIV negative. And just being conscious of that, I think, is probably important. Edwin, you can probably add to that kind of thing.
Actually, well, I just wanted to actually, there was a couple of things you said in your presentation that really stuck out for me that I think we all should really take note of. One is more, I guess, social science, which is a science. And the other one is definitely scientific data that really will help us, I think, with our broader arguments. That you say that once diagnosed, most people living with HIV will change our behavior. Either, obviously, if we take treatment, that renders us uninfectious, or we use condoms, or we disclose, or we do something, or we even abstain. I remember abstaining from sex for a long time after my diagnosis. And I think it's really important when one's making arguments around whether we need laws around HIV criminalization targeting people who know their HIV status. It's actually, they're the wrong people to target, because in fact it is the undiagnosed who are the drivers of epidemics, of HIV epidemics, and TB epidemics as well. And in fact, anything you can do to make it easier for people to be diagnosed and get on treatment, which would involve reducing stigma, reducing discrimination, reducing criminalization, as well, of course, increasing access to testing and lifelong affordable, safe treatment. All of those are the policies that we need. So that's science, and that's obviously not necessarily in a courtroom. Although I was going to add to this idea what else judges and juries and prosecutors also get wrong around HIV, apart from the fact they think it's a death sentence, is that they think the first person diagnosed in a relationship is the person that brought it into a relationship. And that's definitely been the case in lots of the prosecutions that we've seen here in Africa, where there's really a lack of understanding that, and it's been highlighted over the last 2 days, that of course women are often the first to know their status because of antenatal testing. Men do not engage in healthcare, particularly anywhere in the world, other than perhaps gay men in the global north. And therefore, many people, it's impossible to actually ascertain just based on a diagnosis or based on medical records that the person who's accused actually was the person that brought HIV into the relationship. So that's often a huge misunderstanding.
Thanks for that addition, Edwin, and the responses. So we have one question from the people on Facebook or online streaming.
We have two, actually, both on undetectable viral load. Chietza Cheshire asks, does the undetectable viral load state have an expiry date? Is it a state that you will remain on forever? And the other question from Mitsuo Hosokawa is there any difference between HIV-1 and HIV-2 in terms of stability of undetectable states and possibility of transmission?
Thank you. And anyone else from the audience we are doing our last round of questions, so it's now or never. I've seen your hand, you get the first slot. Any other questions, even if it's not about criminalization? 2, 3, again, well done. 4, and who's going to be the 5th and final person? Go ahead, sir.
Yes, my name is Bamidele Jacobs. I come from Nigeria. Now, my question revolves around the impact that geographical factors have on HIV. And I ask this question because I was privileged to be part of a team who was actually defending a woman that was fighting the issue of custody in one of the courts in Nigeria, in a city in Nigeria. And we called an expert, a witness in that case, and in the course of giving evidence, the judge along the line told us, he said, why do you all subscribe to these Western ideas that they have different geography from us? So the question has always been with me, do geographical factors have any effect on HIV? Thank you.
Number 2.
Thank you. I want to ask... je vais faire français. Je voulais demander une question qui m'est fréquemment posée là-bas au Niger. Ok. Non, je ne vais pas vous dire ça. Faut que je fasse français.
But he had begun speaking English.
No. My colleagues.
Go ahead, I think we're all set now.
Ok. Je voulais savoir, parce qu'il y a une question qui m'est fréquemment posée lorsque je parle des cas indétectables, et ça veut dire non-transmission du VIH. Donc, fréquemment, les gens me demandent la question de savoir, est-ce que, pour une personne qui est indétectable, est-ce que tous les rapports sexuels, traumatisants ou non traumatisants, peuvent ne pas être contagieux, peuvent ne pas être contaminantes? Parce que je crois que on a parlé de 80 rapports tout à l'heure, 80 rapports sexuels pour avoir le risque de contamination. J'aimerais savoir, est-ce que, y compris les rapports traumatisants ou non traumatisants? Merci.
Okay. Number 3.
Thank you, Kuzila from Zimbabwe. I wanted to ask concerning the undetectable level viral load. Say, for example, it's a couple and they test HIV positive. then at some point they have an undetectable viral load. Is it safe for them to then have sex without the use of condoms? And for how long is it safe for them to have sex without condoms?
Number 4.
Je suis Nicole du Gabon. Donc, mon intervention, c'est pas une question. Je voudrais juste partager un peu une situation préoccupante du point de vue du VIH et puis de la loi au niveau du Gabon. Jusqu'ici, nous n'avons pas de loi criminalisante. Donc, à chaque fois où ils ont essayé d'initier un projet de loi, ça a été bloqué. Mais à contrario, toutes les fois où une personne vivant avec le VIH est allée se plaindre au niveau du tribunal pour un cas de licenciement pour cause de VIH ou alors pour un cas de divulgation du statut ou de diffamation. En tout cas, à chaque fois qu'il y a eu un problème en lien avec le VIH, de manière systématique, le tribunal a toujours classé sans suite. Et donc, du coup, ça fait en sorte que les personnes sont fragilisées, en fait. Donc, je voudrais juste demander, face à ce type de situation, qu'est-ce qu'on fait concrètement? Merci.
And finally, number 5.
My name is Benedict Tembo. I'm a journalist from Zambia. I'd like to find out how much medical research are you doing to find a cure for HIV and TB in Africa as a whole and Southern Africa in particular? Are you collaborating as universities or research institutions to find a solution to these problems? Or we are still relying on the West?
Thank you. So we take over the 7 questions and a few comments to the panelists, and then we wrap it up.
So I'll keep it quick. The expiry date on viral load undetectability, in the old days we used to say you will get resistance to the drugs and eventually your viral load go up and then you'll be transmissible. The new classes of drugs, we've had people on treatment now for 12, 15 years who've never had a viral load detectable. You know, 15 years, you said 25 years, and you've never had a viral load. And no, did you start treatment? You said 92, 2002. So that's 15 years, viral load never detectable. That's now nonsense. And with the more powerful, better tolerated drugs, we actually quite horrified when we see patients who are detectable. So if you stop your drugs, the virus comes back. How quickly that happens varies from person to person. The longer you've been undetectable, the longer it takes for you to become detectable again. Usually that happens, though, within weeks to months. Some people are what we call have got some genetic condition where they're able to control the virus for longer and they can keep it under control for longer. But the only way to test that is to actually take blood to make it happen. The question between HIV 1 and HIV 2. HIV 2 is actually a disease that's slowly disappearing from the world. There's a fascinating history about HIV 2, which HIV 1 potentially could have followed, but there's all sorts of historic reasons in Central Africa as to why that didn't happen. But HIV 2 appears to be transmitted in a very similar way. It's much harder to transmit. The drugs are equally effective, and it seems to stop the transmission as well. I've only ever seen one case of HIV 2, and it was somebody coming from Western Africa, where it's not really a Southern African disease. So as I said, it's actually more of an academic concern. There's a small pocket, probably tens of thousands of people with HIV 2 who are able to access treatment. We use the same drugs. There's certain drugs which don't work in HIV 2, but most of the commonly ones that we use actually work for HIV 2 as well as they do for HIV 1. The question of Nigeria and geography is, to my mind, one of the biggest questions in HIV is why is 70% of the population of HIV people in a small little what is it there? Now, and I think it has to be something genetic, and people say, oh, it's black people, for instance, because they're all black. But there are lots of black people. There are places like Senegal, which have got a lower HIV prevalence rate, where only black people pretty much live, compared to America. And in certain countries, so it's not about race. It's got to do, I sometimes think it's about like Kenyan, the fact that Kenyans dominate these marathons totally. So people could, on the face of it, say, it's something we can see. It's black people who dominate those marathons. If you go down to it, it's all Kenyans. There are no South Africans there. There are no Botswana, no, there is a Botswana, but there are no Namibians there. But actually, if you go to Kenya, it's actually one small village, actually, where they come from. So it's about, I think, probably about a risk that is actually genetically mediated. There might be something about nutrition. There might be something in environment in that geography. Who knows? But we haven't put our finger on it. But you can't tell me it's sexual behaviors unless... I always, when I teach, I talk about a young black woman in KwaZulu-Natal in South Africa has a 3,000 times greater chance of having HIV than her counterpart, her age-matched woman in Europe or America or in India. What's that about? What sexual behavior drives that? Unless she's having completely like 3 partners every single night drives that sort of risk. It doesn't seem plausible to me that it's about sexual risk. Sex is what drives it. But what is in the background has to be something else in the background, either genes or an environmental factor that's making them so much more susceptible to HIV. So your question's a good one and is unanswered to my mind. You asked about undetectability. This was the French, I hope I got the question right because it was translated, is about undetectability. Your risk of getting HIV is related to several factors. How high is the viral load? If the viral load's very low, your chance of transmission is very low. If it's very, very, very high, which is often the case in early HIV or when somebody has very advanced HIV, the risk is much higher. But there are other factors as well, is how much is the load? Is there sexually transmissible infection at the time of transmission? There's some debate if your viral load is very low, if it matters whether there's a sexually transmissible infection. But certainly if your viral load is very high, sexually transmissible infection seems to add to the risk of transmission in that point. So when we say undetectable equals untransmissible, it's because we know in that situation we've got lots of data to suggest that transmission is not going to happen. Otherwise, there are other factors around it. That's why I said, like, rape, for instance, is a very high-risk injury because the minute there's blood involved, if you have sex during a woman's menstrual cycle or if there is violence involved, the risk goes up if the person is undetectable, if the person has a detectable viral load. The question about what do we say to partners who have an undetectable viral load, they will tell you themselves, they throw away the condoms after a while. Nobody likes condoms. The only people who like condoms are people who are not using them. I can tell you, it's public health people who like condoms. Nobody will continue to use condoms. There's consistent data showing long-term relationships. It's one of the first adaptations within the sexual relationship that people do. So I say to partner, when I counsel my patients, I say, listen, you don't have a viral load just before you have sex, okay? You have to trust your partner that first they're giving you the right result and that they are watching themselves, they're swallowing their tablets, that they're doing what they're supposed to do. If the viral load was undetectable 6 months ago and they haven't missed a dose, chances are almost certain that they are virally undetectable. And people, I think, and then I say to them, it's up to you to throw away the condoms. My view is that your risk is very, very small. It's probably not 0, 0, 0, but neither is getting in the car to drive across the city. You know, it's part of what makes us human, taking a series of risks. You're going to handle the Gabonese. Your question about the cure. Now, remember I put up there the thing about life expectancy. There's several studies showing that people who have HIV are actually living longer than HIV negative people. So rationally, you can even say to somebody, why would you want to be cured? You're going to live longer than somebody who's HIV negative anyway. So why? And especially when the drugs we're using for cure are often very, very toxic that we're looking at the moment. Now that is again glib because people internalize stigma by being HIV positive, and it's a very emotional thing. We have no problems recruiting people for cure research simply because they are dealing with the stigma associated with HIV. The data, most of the cure research is being driven within Europe and America, but increasingly here in sub-Saharan Africa. So we're part of a whole lot of collaborations looking at cure. I can tell you that it's a long way away. We're looking at decades to my mind, if it's humanly possible. When my friends are all involved in this, if you give them 3 glasses of wine, they say they're not sure it's going to be possible. And this is their research careers. And I think it's important for us not to get hope for the cure because it's probably not going to be in our lifetime going to be available. And the beauty of it is, it's horrible to think like that, but on the other hand, we do have treatment that is incredibly effective. You might want to address some of my comments.
Yeah, thanks, Francois. So just very briefly, the question from Gabon, it's not so relevant to this session on science, but you're asking about because there's no HIV-specific law, generally, whether it's a criminal law or a protective law in Gabon, then when people go to the court because they've been discriminated in employment or have lost privacy, the courts are rejecting it. I think that's a conversation to be had on the next 2 days about how to address access to justice in the context of broader issues around everyone's right to non-discrimination, right to privacy. Perhaps you don't need an HIV-specific law to deal with that, although many countries in Africa do have HIV-specific laws to deal with those things, and then have added these problematic statutes around non-disclosure, exposure, and transmission. One of the things that I think is perhaps still quite new information to many people in the room is that treatment is also prevention, and that what I really loved was that it is now possible to say, we used to say when condoms were really, ABC, but condoms really were the only way to prevent HIV, that it was safer sex. And I love the fact that you say sex can now be safe, certainly around HIV acquisition or transmission, either when the person is on treatment and has a lower undetectable viral load, or if the HIV negative partner is taking PrEP, pre-exposure prophylaxis. And when you ask questions about how do we reframe that kind of messaging from a public health perspective, and I think the work that's being done around HIV criminalization is helping for us to understand this, that in fact the risks are nowhere near as high as people they've always been made out to be. And now we have incredible tools, although they are biomedical, and that does require access to clinics and ongoing antiretrovirals. But that's reframing how people actually are perceiving sex between people who are HIV positive and those who aren't. And the message that the U=U movement, which began last year in the US and Canada and has now been embraced by some in the global south, but not all, is quite remarkable in understanding that treatment is prevention. But I think I asked you this question earlier about the fact is that many people do not have access to viral load testing. Many places, many clinics do not have viral load testing. And certainly many people don't have access to long-term quality antiretroviral therapy. But even in that context, the risk at risk of transmission, even someone who's not on treatment, is much lower than people think. And that it's also modified not only by STIs, but also the kind of sex, so whether it's anal sex or vaginal sex, or whether the insertive or the receptive partner. You said it was easier HIV made it easier to talk about sex. We haven't actually gone into the squidgy, actual what we're talking about, because courts are not the place where it's very easy to talk about sex, and yet they do. They are analyzing. Okay, and I just wanted to highlight, even before the Swiss statement, the very first court in the world to actually look at this, and it changed the law, it was in the Netherlands in 2004. And they actually looked at what was the risk of receptive anal sex. And they decided, and in this particular case, a man the complainant had been penetrated 3 different times by a man on treatment but without condoms. And they decided, even back in 2004, that because it was 3 times, even with anal sex, which you say is a 1 in 80, they recognized then the prevention impact of treatment and said that the risk wasn't considered to be high enough for them to prosecute someone, and it changed the law in the Netherlands. So science can make a difference, and I just wish that all expert witnesses were like you, Francois.
You can truly tell how passionate Edwin is about this particular subject. He can speak to it till the sun sets. So I think our panelists deserve a round of applause.